and what's the relation between food allergy and eosinophilic esophagitis, and we'll talk about update in management of eosinophilic esophagitis. Eosinophilic esophagitis is one of the chronic immune-mediated esophageal disorders characterized by esophageal dysfunction and eosinophil infiltration. However, eosinophilic esophagitis become emerging entity because you will see the number of publication is increasing, the number of publication increasing progressively. So I think the reason because increased awareness of this disease to gastroenterology and could be related to atopy disease. We show our first data, eosinophilic esophagitis in Saudi Arabia. We conclude that any history or index of suspicion for any child with atopy, failure to thrive, eosinophilia, trachalization is increased risk or index of suspicion of eosinophilic esophagitis. So the old definition of eosinophilic esophagitis, you have symptoms of esophageal dysfunction in younger or older children and adult, mainly food impaction, with pathology including more than 15 eosinophil per higher field, and we give trial of proton pump inhibitor for 4 to 6 weeks and to repeat endoscopy to see if it's still persistent or not. However, they discovered in the last 3 years a disease called PPIRE, proton pump inhibitor responsiveness esophageal eosinophenia, but nowadays it's become a new disease, or it become the new eosinophilic esophagitis, because they discover there are no clinical or histological differentiation between disease, and they found that the gene or T helper 2 gene expression are present in both disease. So the new definition now is we have 3 pillars of eosinophilic esophagitis. One, histology, symptoms, the other histology, and the last thing, exclusion of non-eosinophilic esophagitis. For the symptoms or histology, the same, you should have at least commitment of atopic disease with endoscopic finding, including exudate, furrows, and others, with histology more than eosinophil per higher field, restricted to the esophagus only, and exclude non-eosinophilic esophagitis, which is eosinophilic gastritis, gastroesophageal reflux, echinacea, parasitic, Crohn's, autoimmune disease, all are present with esophageal eosinophilia. So I think it's fair enough to put this new diagnostic criteria by expert group in eosinophilic esophagitis to exclude this disease. Endoscopic finding, however, it is not sensitive or specific. In our GI practice, if you see trachalization or esophageal ridging or white speckles or food impaction or strictures, we think about eosinophilic esophagitis. However, you may have 30% normal endoscopy. So the best is histology. So this is why we always sit with our pathologist to count the eosinophil, usually more than 15 eosinophil per higher field. And sometimes we ask them to look for eosinophil microabscess for grading and staging, and sometimes looking for dilated intracellular space. So the question now comes, are the skin prick test or patch test or specific IgE is useful or triggered to eosinophilic esophagitis? First of all, we know that food allergy and eosinophilic esophagitis, it is antigen-mediated disorders. And in this cartoon, it will demonstrate how the food allergen and aeroallergen trigger the barrier function, leading to recruitment of eosin 3 and interleukin 13, leading to acute inflammation and chronic inflammation. A very interesting finding, they found that there are some gene abnormalities will trigger to barrier dysfunction. The most recent finding, which is very surprising for us, that they inject food allergen in the esophagus. and they observed 24 hours, and they found that there is real inflammation, and comparing to the placebo or control, they found that dilated histamine. So they conclude that esophageal injection in the esophagus induce acute or delay responsiveness in eosinophilic esophagitis, not uncontrolled. So it's very promising that I'm expecting that maybe we'll do this test instead of skin test, because it's a small number, but they are ongoing another trials to demonstrate that esophageal injection food allergen, it will demonstrate it is restricted to esophageal response to the food. It's very, very, very interesting studies. So they conclude that the eosinophilic esophagitis is a special type form of food allergy. It is non-IgE mediated disorders, no immediate symptoms with a trigger, and alhamdulillah, there is no life-threatening conditions like anaphylaxis and others. Another question or another concern is the eosinophilic esophagitis IgE disorders. The answer, it is non-IgE disorder. Why? Because the positive predictive value and negative predictive value is not too great for skin test and specific IgE. And more interesting, they inject monoclonal IgE antibodies, and they didn't see any response. And the most recently, they found that there is strong evidence that IgG4 instead of IgE play a role in eosinophilic esophagitis. So I think there is strong evidence that eosinophilic esophagitis is non-IgE. Another promising or serological markers, instead of endoscopy, they do string test, they do cytosponge, and sometimes they do esophageal biopsy for transcriptome analysis. Now we'll come to the management. We have three parts of management, either topical corticosteroid, or diet intervention, or proton pump inhibitors. Topical steroid is still the first line of the treatment. So, including multiple systemic review and meta-analysis, and we found that almost more than 2/3 they have sustained response at the age of 2 years. So, topical steroid is more safer, and you can use what kind of topical cortisone. So, this is the meta-analysis shows that favor the steroid. Not only symptomatic response, even histological response and endoscopic response. This is another meta-analysis, shows they found that these favor the topical steroid rather than control. The other question is what kind of steroid? We have some data that budesonide oral suspension improve symptoms, improve histological, and improve endoscopic comparing to the placebo. So it is one of the drug of choice for eosinophilic esophagitis. More recently, they found that oral viscous budesonide is better than swallow fluticasone, whatever you give it in fecals or others. And more recently, we have budesonide oral dispensable. They put it under the tongue and it's dissolved and looks like viscous. So they found that it's more histological response and more change to eosinophil post and pre-endoscopic. If you compare between BBI and topical steroid, we found that as response, you will see the corticosteroid is better than BBI, but the main thing is candidiasis, while in BBI, we'll see it is the eosinophil count and histological better for BBI. What's about diet? The diet intervention, it is a little bit difficult for pediatric eosinophilic, and this meta-analysis shows that elemental diet in the form of amino acid-based formula, it will induce histological and clinical response for eosinophilic esophagitis. Another diet intervention, we call it allergy testing diuretic food elimination. This meta-analysis shows most better response, and even more better for long-term outcome. And if you compare between 3 diets, including elemental diet, 6 food elimination, including milk, gluten, egg, legumes, and nuts and fish, and the last thing, allergy testing diet. You see elemental diet almost reaching more than 90% in induced remission, comparing to 6 food elimination, comparing to allergy testing. So this is the only data shows that elemental diet is still the choice after steroid. Very interesting studies, we call it 2 and 4, 6 studies. This is in both pediatric and adult. First of all, they eliminate milk and gluten, they repeat endoscopy, they induce it, then they add another 2 food allergen, then add another 6 food allergen. It is a little bit advanced because you need to do at least 7 endoscopy in 1 patient. So I think nowadays it is outgrown, they will not do it anymore for this test. Another question is, what is the mechanism of proton pump inhibitors? We know that it works in acid reflux. So how to work? It works by block interleukin-3 signals, which is the main thing for eosinophil introduction, and also it will improve the barrier function that leading to recruitment of the cells. And you will see here almost more than 50% the BBI, they have clinical response and histological response. And this is the BBI meta-analysis shows that mainly affecting clinical response rather than histological response. My conclusion or our guidelines in eosinophilic esophagitis, first, we give option to the parents, which one you want to start. Usually, in my practice, I use topical steroid and BBI. Then I reevaluate after 2-3 months by 3 categories: endoscopy, histology, and clinical. If he is response, I will keep him in maintenance or low dose. If he didn't respond, I will see if he is active inflammation. If the patient in steroid, I do reinduction. If the patient in BBI, I switch to steroid. If the patient in diet, I switch to the steroid. So the it will be steroid. So this is why I started in the beginning topical steroid. If the patient has remission or strictures, the dilatation becomes a choice for eosinophilic esophagitis. Why I didn't choose diet? Even they are both are 50 to 90 or 50 to 80%. Both have good safety profile, but the diet is very expensive. And you know that the bottles of amino acid-based formula, it costs more than 200 riyals, in addition to the flavor. And the most important thing, they are restricted. They have psychosocial impact, while in steroid, they feel they didn't interfere with the quality of their life. So what's other new modality of treatment? Rizulizumab is one of the antibodies, mono antibodies blocking interleukin-5. It is promising agent. It is demonstrated in RCT trials that by the symptoms, by the histology, and by the global assessment, which have better response at the dose of 2 to 3 milligram per kg, and we still need more data to make it in our practice. Another promising agent is called interleukin-13, or we call it QUAX576. If you see here, comparing to placebo, you will see the response rate up to 40% and eosinophil count decreasing by almost 60%. And we expect this medication, based on adult and pediatric data, it will ongoing, first of all, for non-response for steroid, because they found that it is well tolerated and it is a safe medication. Another medication, we call it CRTH2, which is chemo attracting receptor homologous molecules on T cells. And they found that when they compared to the placebo, they found that before and after treatment, you will see the eosinophil count good response. with this medication, while in placebo, they have the same no response. So this is why they improve the physician global assessment, and even they reduce extracellular deposit of eosinophil and transient C. What's about leukotriene inhibitors? Some studies, or no enough data to demonstrate in our practice, they didn't reduce esophageal inflammation, and they found that metoclast is not superior to the placebo. In our practice, is not recommended use in treatment. My conclusion that eosinophilic esophagitis is immune esophageal disorders with symptoms and predominant eosinophil inflammation. The conditions associated with esophageal esophagia is a part of diagnostic criteria. We should exclude non-EOE, and we have enough data that eosinophilic esophagitis is non-IgE mediated disorder of mediated food intolerance, and topical steroid is still the first line of the treatment. However, we prefer it because they are not restricted or not interfere with the quality of the life, and other new treatment of eosinophilic esophagitis are promising. And for anyone who is interested in eosinophilic esophagitis, this is the new recent guidelines from European Gastroenterology, and the bottom is the new guidelines for pediatric eosinophilic disease. And anyone interested in research, this is Conostrum for expert eosinophilic esophagitis. If you have any questions or anything or related, their website, they will answer to you quickly. Thank you very much.